Appreciate it. Great. So thank you. Let's move on. So you'll see the QR code there. If you scan it, it should join Poll Everywhere. You can also see at the bottom, if you get lost, pollev.com/A007. And that will give you a site. You can put in a username there, whatever you want. And then that will allow us to hopefully have some form of interaction. So the objectives for this evening's talk is to introduce concepts of study design and really to help differentiate between descriptive and analytical studies that we commonly see in the medical literature. I hope you'll be able, by the end of the evening, to list 2 descriptive and 3 analytical study types. I also hope that you'll be able to know and begin to apply the finer criteria to study design. Okay. My internet has had some issues here in Bomet, but I really hope that it stays stable. If it doesn't, I will change over to another one and I'll join you as the connection continues. All right, so start with definitions. We're still early in the workshop, so I can still get away with defining things. But let's say a research study is the systematic investigation to answer a question using data from a population to create generalizable knowledge. So there's a couple of words in there that require a little bit more definition to get to the definition. So what does systematic mean? To me, that means that there's a hypothesis, a plan, there's some kind of organized methods, the way that we collect data and then have a plan to analyze it and draw conclusions from that data. And then generalizable means that it's intended to provide information to others. So as doctors, we investigate things every day, but to make it into research, it's a systematic plan. And then as doctors, we often do quality improvement at our hospitals. But when it begins to say that we're going to generalize that, we're going to provide information for others to learn from us, that gets into research. Good. All right. I might not be able to monitor the chat too much, so avoid the temptation to answer the questions in the chat and just try to answer them in Poll Everywhere, which you can find at the bottom of the screen. All right, so this funny comment, well, while doing the research, keep in mind, there are only 2 kinds of facts, those that support my position and inconclusive. So you might know some of these professors, I certainly did, who use research to confirm the bias that they already have. But my hope, and the hope that I'm sure all of you share, is that when we do research, we're genuinely trying to answer questions with humility and curiosity. Okay, now this is just a brief display of some of the things that we're going to talk about, but I just wanted to lay it out here to show that there is a pyramid of evidence that we make decisions on so that we understand when we do research, the different study designs we use help to answer questions, and those build on one another. But we'll get into some of these. And I like my job because I get to introduce study designs. And in the sessions to come, you should be able to learn a bit more, kind of diving deep into the different study designs. All right, so we're at our first our first question. We're going to try, if you're just now joining, try to scan the QR code or go to the URL, pollev.com/A007, create a username, and we'll have some questions. All right. So this is just for a bit of fun, to have some interaction. The winner just gets the respect of your peers. And if you do all of the things that are required from the course, you'll get a certificate. But there's no prize, full disclosure. All right. So question, why do we do research? Why do we do research? To improve care for your patients and community, to share your experience with others who could benefit, to understand the burden of disease in your setting, to develop problem-solving skills, or all of the above? All right, so you can see that there's a timer. You have 14 seconds left to answer the question. Hopefully on your device or on your screen, you're able to see this question and you can select it. All right, time is up. We are locked. Next. Good. Okay. We have answers. Yeah, I agree. All of the above. That's good. We talked about this a little bit in the introduction, but my goal for research is to do each of these things. We all have our own motivations, but I hope we can all share some of these motivations. Okay, so again, because I have the audience, I like to share some advice about research. I believe that research should be motivated to improve care because as doctors, that's really what we want to do, is to improve the care for the patients that we see. And it's because of the patient, that's why we do research. I also believe that research is a team sport, that we are in it together. When you try to do something on your own, you're often missing the opportunity to learn from your peers, for other people to bring certain skills or gifts. So I think when it's done on a team, often with a leader and a mentor or a coach, it can be done really well. Understand that we are all learning, that there's no one who has all of the right answers. And as we'll learn about each of the different study designs, they all have their limitations. So we could be at a conference and you could present your study type, and I could immediately tell you why your study is flawed. That's just a part of it. We know that there are no perfect answers, and we know that we are all learning. And we should have the humility to be able to ask the questions and be confident in our results. So I think when we do research really well, we end up with more questions than answers. It's always building, just like on that pyramid of evidence. We're building more and more questions as we answer. So again, if you missed the poll, you still have a chance, the QR code and there. So, all right, we have the leaderboard. Excellent. So you can already tell that it is time-based. So the quicker you put your answer in, the more points you get, just to make it a little bit more challenging. It's part of the fun. All right, next question. A sample of a population should be, all right, avoid the temptation to answer it in the chat. Try to answer it in the thing. If you're not able to select, that's okay. Again, this is just for fun. There's no prizes. You don't miss out on anything. You still get credit for participating here. Okay. A sample of a population should be random and representative, small and selective, comprehensive and chosen by the investigator, exhaustive and exclusive. All right. 15 seconds. If you're not able to key it in, just kind of reflect and think about what you would answer and see if you're right. Okay, that's locked. Great. Okay, sample of a population should be random and representative. So there's a couple of buzzwords that go along with a sample. I'm I don't necessarily disagree with the choice comprehensive and chosen by the investigator, but I like my answer better. And it's not necessarily wrong. Sometimes a sample can be small and selective too. But um, the ideal sample is random and it represents the population. So it's kind of the best answer. But again, we're all learning. So when we're asking our research questions, we would like to draw conclusions from the group, and that group is the population. Uh, to be able to ask every single person or individual in that population, that becomes a census. But a census requires a huge amount of effort and time. It's very resource intensive. So a good way to learn about that population is to take a sample of that population randomly, but in a way that represents the entire population. And then from that, we can ask the questions or learn about that sample to then make inferences about the entire population. So if your sample is flawed, then your study is flawed. So part of study design is creating a good sample, one that is random and representative. All right. Okay. Still in the lead with a very quick turnaround. All right. Good. We'll see if your name's on there. Good. Um, again, no prizes. All right, so study process. As we think about study design, we have to think about the whole research process. You know, we start with a research question, and I can't emphasize that enough because so often we want to just do the study. But if you don't have a question you're trying to answer, you're already starting off on the wrong foot. So you want to develop a strong research question and then select a study type, collect and analyze data, interpret the results, report the findings, and the whole thing needs to be done in an ethical manner. So that's the study process, but we're here this evening to kind of get an introduction to study design and to help us to select a study type for the question at hand. So when we think about study designs in kind of broad categories, they can be either descriptive or analytical. And in the descriptive category, we have ecological. So that's kind of taking a population and maybe finding a correlation. Um, there's a case report or a case series where we maybe describe the experience of one or a few or a series of patients. There's a cross-sectional study, which is a snapshot in time. And then we have our analytical uh, studies kind of in a separate branch where we both have experimental, often kind of the randomized controlled trial, which is our gold standard in medicine, or observational, like a cohort or a case control study. So we're going to talk a little bit more about these as we go on. Um, but some of the important things to recognize when we're designing a study or we're interpreting a study is that one study is not enough. It requires the totality of evidence. So if you find one study that contradicts hundreds of other studies, that one study, it might be valid, but really kind of give it some pause before accepting that as truth because you need the totality of evidence. You need everything to consider. So when we're picking a study design, recognize that there are different strategies for answering a question. And we'll get into that, and you'll get into that even deeper as the weeks go on. But then the choice of why one study design versus the other not only depends on the question, it also depends on other factors like the cost of doing the study, the resources available to you, the feasibility of the study, and the ethics of a study. So while one study might be the ideal or the gold standard, it may also not be an appropriate study. So each design has inherent advantages and disadvantages that will limit and create bias. So we'll talk a little bit about those, but I, I, I want to really emphasize that every study design has its problems. Uh, all right. So next up, question. You publish a paper that reports your experience with 15 cases of small bowel volvulus. This paper would best be described as hypothesis testing, descriptive, randomized, interventional. So feel free to uh, um, answer that in your device or on your screen. If you've just joined, just kind of answer it as we go along. Take the time to reflect. You still have 5 seconds to get your answer in, and we'll see if it's the same as mine. Okay. All right. Yeah, the majority of you would agree with me that it's a descriptive study, also known as a case series. Uh, and Yeah. So when we think about the two different types, the descriptive study versus the analytical study, the descriptive really tries to answer the questions of who, what, where, and when. And the analytical studies often just try to answer the question of why. So those are your um, interventional studies where you do an intervention and you try to figure out why something happens the way it does. Or it's a hypothesis testing approach where um, whatever you're doing, you have a hypothesis and you test it through an analytical study. But that case series, there is not a comparison group. So you're not really testing a hypothesis. And there's not an intervention. You're just describing your experience with small bowel volvulus. And that could be really helpful for a surgeon like me who wants to learn about your experience with small bowel volvulus so that I can know how to best treat small bowel volvulus in my context. All right, so we'll keep on moving. A case report or case series is the most basic type of descriptive study for individuals. It's a careful, detailed report of the profile of the individuals or the series of patients that focus on factors that could be related to illness or outcome. It's often the first alert to a problem or a solution. For example, we have to start somewhere, right? COVID-19, we learned about it from a case report. Um, the first person to see an association between tobacco smoking and lung cancer was a case series. They were alerting their peers to this potential idea to say, I think there might be something worth exploring and asking more questions and building on. There's no measure of effect or comparison. It's really just generating a hypothesis. All right, here's our leaderboard. Wow, good. All right, next question. You perform a well-designed study involving a sample population of married medical students at University Medical Center in Zambia. The findings from your study can be generalized or applied to which population? All right, all married medical students at University Medical Center in Zambia, all married medical students at any medical school in Zambia, all medical students at University Medical Center in Zambia, or all medical students within Zambia. 10 seconds. All right, it's locked. Let's see what we got. Good. Okay, I agree. So, all married medical students at the University Medical Center in Zambia. Uh, so that talks a little bit about how generalizable your study is to others. And as I shared previously, but I'll share again, where most of the research literature is published is in Europe, North America, East Asia, and not very much is represented within our region. So always understand that perhaps the studies that we see may not apply to the patients that we care for, right? It might not be generalizable to our patient population. And when someone tells me that and they say, well, that study is good, but it doesn't apply to my patients, then my encouragement is to do that study so that it does apply to your patient or it doesn't, and you could show a difference. And so it's an encouragement to ask the question within the patient population if you don't think that it applies. All right, good. We've got a new leader on the leaderboard. It's a tight competition, as you can see. Next up, you conduct a survey about the use of helmets for riders and passengers of motorbikes in 6 counties in your country. This would best be described as a A case series, a cross-sectional study, a prospective cohort study, or a case control study. All right, you're conducting a survey about helmets. How would it be best described? Feel free to answer in your poll. The link is pollev.com/A007. I'll type it in the chat, pollev.com A007. All right, so time is up. Let's see. All right. Cross-sectional. Okay. Yeah. So a cross-sectional survey is a snapshot in time. So at one moment in time, you want to find something. Often the prevalence is what we're typically using a cross-sectional survey for. Um, and it helps to generate a hypothesis. We're not really testing a hypothesis. In our example, the riders and the passengers, we're just looking at whether or not they use helmets, right? Where we might be asking them other questions about why they're using a helmet or they're not using a helmet. But really, we're in that example, we just wanted to know, are you using a helmet or are you not? And this can serve as a needs assessment to say, wow, no one is wearing their helmets. We could perhaps ask more questions like why? Or we could design an interventional study and provide some helmets and see if there's any difference. So, um, yeah, so hypothesis generated cross-sectional survey. Okay, hanging on to the lead, but it is tight. All right, next question. Which of the following is true of meta-analyses? Meta-analyses eliminate selection bias. Meta-analyses correct flaws in study designs by using the results from multiple studies. Meta-analyses measure the effect of an exposure on an outcome using statistics. Meta-analyses use unique statistical techniques to arrive at conclusions. Okay, meta-analyses. 5 seconds. There's no harm in guessing. Make sure you try. Good, we're locked. Okay, this one was um, a bit more controversial, but still the majority agree with me. Meta-analyses measure the effect of an exposure on an outcome using the results of multiple studies. The next one, meta-analyses correct flaws in study design by using results from multiple studies. That I could see could technically get it, but I think the better answer is using the results from the multiple studies. And the reason why I think that is that meta-analyses are only as good as the studies they are studying, right? So you take each of these studies and then we put them all together and use statistical techniques that are common to other studies. Um, but we combine all of the patients, for example, and see if the exposure is related to that outcome. So if one of the design flaws was that the study was underpowered, then the meta-analysis could correct that, and you could be correct by selecting B. But the meta-analysis doesn't really correct the flaws from that underlying study. So if that study has bias, it will feed bias into the meta-analysis. So the meta-analysis is only as good as the studies it's looking at. There are cool statistical techniques to examine for that bias, like publication bias, which is if that we as researchers really like to publish positive results, and we often kind of don't publish our negative results. So there can be a publication bias that happens, and there are statistical techniques to look and evaluate for that. All right. Oh no, a new leader. Okay, good. But it's still tight. There's still time. Doing great. All right, another question. You are wondering if sigmoid volvulus is related to childhood abdominal trauma. This is a question that you developed that you just want to see if it is true. So you compare the rates of abdominal trauma in a group of patients who have sigmoid volvulus um, to a similar group of patients without sigmoid volvulus. This is a case control study, retrospective cohort study, prospective cohort study, or a randomized controlled trial. Okay. You guys have really learned about how to answer quickly. It's like we're flying through it. I love it. 10 seconds left. All right. Case control study. All right, I agree. I think this one is often a bit difficult on surgery exams. It's a typical MCQ where you're trying to get the right answer. Is it a case control study? Is it a retrospective cohort study? Is it a prospective cohort study? And for a lot of years, I was quite confused about that. But hopefully, through this talk, we can kind of get at uh, the answer there. All right. So, brief overview of analytic studies. Remember, we talked about this is the why. As researchers, that's what we care about really deeply is why is something happening? Why is this impacting my patient? Why is it working to make them better? So analytic studies are designed to improve on the limitation of the descriptive study designs, which really just tell us who, what, where, when. But um, this is helpful. So the issue with correlational studies is that analytic studies go to the individuals, not just like the whole population. It has an appropriate comparison group. So that's our issue with case series where we just have one group but no comparison. It has an appropriate time sequence where maybe we measure over the course of years following patients instead of a cross-sectional study, which is just a snapshot in time. And then also analytic studies help to control of confounding factors, which we'll touch on briefly here in a moment. All right, Moses is staying in the lead. Strong work, but it looks like others are out to dethrone you. Okay, next up, you design a study to compare patients who had core breast biopsy done under ultrasound guidance with those done by palpation alone. You follow the patients to determine hematoma rates between the groups. So you design a study comparing patients who are undergoing core breast biopsy and comparing those with ultrasound guidance with those done by palpation alone. This study would be an example of a case control study, a randomized controlled trial, a cohort study, or a case series. Okay. All right. 2 seconds left to get your answer in. Good. We're locked. Let's see what we said. Awesome. Okay. So cohort study, I agree. We'll talk about why I think that is the case. Okay, so this is a bit of a busy slide, but bear with me. Um, this is each of those confusing things about uh, a, a prospective cohort study, a retrospective cohort study, or a case control study. And I think it's helpful to kind of think about um, where you're starting. So the researcher is the little guy with the stethoscope on, and where are they in relation to the outcome and or in relation to the exposure and the outcome, or often the disease, right? So if you are thinking about a question and you are starting with the exposure and you're following patients until they do or they do not develop the outcome or disease, that would be a prospective cohort study. So research subjects are chosen based on whether they've experienced some exposure. For example, smoking or not smoking. And it is unknown whether they will develop the outcome or the disease of interest, for example, lung cancer. So the outcome occurs after the study begins. So a prospective cohort study, it takes time to follow them up, and that often takes resources to be able to have the capacity to follow all of those patients until an outcome develops or it doesn't. So in our example of breast biopsy, the exposure was undergoing a biopsy with ultrasound guidance or palpation alone. And then we, the investigators, follow over time to see whether or not a hematoma develops, right? So that's a quick outcome. But many times, especially in epidemiology, we are looking over the course of months and even years to see if an outcome develops. All right, so then let's move to retrospective cohort studies. So this one, it's a little bit confusing, but think about it that you, as the researcher or investigator, are all the way over on the side of the screen. Both the exposure and the outcome have already happened. All right. So subjects in this study are still based on whether they experience some exposure. For example, smoking or not smoking, and then compared based on whether they develop the outcome or the disease of interest. For example, lung cancer. But here, the outcomes have already occurred at the time the study begins. So how is this possible? This requires a database or something that you're looking back on. You're studying like an electronic medical record where you're looking back, you're identifying the subjects based on an exposure, and then you're immediately looking, well, did they develop the outcome that I'm interested in? So that's a retrospective cohort study. Um, Good. Okay, then finally, the case control study. So subjects in the study are chosen based on outcome or disease status. For example, you find patients who have lung cancer or their controls, they do not have lung cancer, and then they look back in the past to see whether or not they experienced the exposure, for example, smoking. Okay. So why would we choose a prospective cohort study versus a case control study? And when would we do that? So the if the outcome is rare, if the outcome is rare, then how many patients would we need to follow prospectively to see whether or not that outcome occurred? Right? So think about something like pancreatic cancer. It's somewhat rare, but if we were going to follow a group of people to see whether or not they develop pancreatic cancer over the course of their lifetime, how many would we need to follow in order to find just a few, right? It would be a big population. We would have to enroll a ton of people, follow them, and then see whether or not they develop pancreatic cancer. So typically, an easier way to do that because of the limitations of time and resources would be to identify patients based on their outcome of pancreatic cancer and then find patients who don't have pancreatic cancer and match them in a case control study, and then look back to see what kind of exposure they may or may not have had that could be associated with the development of pancreatic cancer. Okay, so case control focuses on the disease, cohort focuses on the exposure. Prospective and retrospective, just ideally prospective, but more practically retrospective. And if you have a good database, retrospective cohort, because that data was collected along the way, is also a very good study design to help answer your question. So it's based on the question that you have, but it's also based on the individuals you're trying to study. All right, good. Let's keep moving. Here's our leaderboard. Moses staying in the lead. Excellent. You almost forgot that there was a quiz. Okay. All right, so when we develop a question, and hopefully you've been introduced to this a little bit, but we do this every day. Think about a question you've had as you take care of patients. For example, do probiotics reduce infection in GI surgery compared to placebo? Does anticoagulation in pediatric trauma patients reduce VTE compared to no anticoagulation? Does early tracheostomy reduce ventilator days compared to late tracheostomy in patients with TBI? Right? They're all questions. And you can design a study to answer those questions. But come up with your own questions as we go along. Think about things that in a certain population, is there something that is interesting, some kind of intervention or comparison that impacts an outcome that you might want to examine? And these questions are best when they kind of grab you, when like there's a problem with a patient and you want to figure it out. And right now, the literature doesn't yet exist for that, or you're seeing something that's a bit different than the literature and you want to challenge it. So have the curiosity and the humility to do that. Okay. So another limitation with study design is how do you find the data? And this is a big challenge, and one of the reasons why that map of where research is done, I think is such a challenge, because often the source of data to answer the questions that we have are limited. But I would like to encourage us that there are still sources of data that can be available to us. So patient charts and health records, those are available. It's not expensive to design the study, but if it gets to be a large scale project, it becomes a challenge. It helps to generate bigger ideas. The negative is that reviewing charts is time consuming. Often there's missing data because clinicians are busy and they were not interested in your research question, so they were just documenting the things that they needed to document for the day. And that data is not standardized. So these are examples of a case series or retrospective review or retrospective cohort study where you're looking back at things. Sometimes we have disease registries. This could be a cancer or a trauma registry where we have access to clinical data. Prospective collection has happened and often population based. So it's like for a certain population has been collected. Sometimes it doesn't follow patient outcomes. It's like a cross-sectional study where it's like you were diagnosed with cancer or you were not. There's still some missing data in a registry because it really requires registrars to generate that data. Other sources of data are surveys and interviews where you can get really good stuff about patient-reported outcomes. It helps you to get specific types of information that might be challenging with other data sources because you talk directly to the study subjects. There's still bias in how participants are selected on who you decide to interview, who enrolls in your study, and it can be quite labor intensive depending upon the quality and design. So these are the questionnaires that so many of us do. Another source of data for a surgeon like me is operative case logs. When surgeons log their cases, that's often done prospectively, and you can get experience of numerous centers. Still have the issue of missing data and users recording potential errors. Uh, then another source of data is research-created databases. So this is prospective collection where you have a defined, relevant, and desired data points that you want to look at and you collect them. This can be more expensive and timely to collect the data. It requires a lot more work and effort. So you might need data collectors or assistants to help with that. It also needs ethical approval if you're enrolling someone into a study. And all of these need ethical approval, but that one requires informed consent instead of a waiver of informed consent that potentially can happen for retrospective. So it just adds another layer of complexity, but is good for answering a question that the other ones maybe have their limitations. And so then there are emerging healthcare databases where we track large numbers of patients and they're population based. Access to those can be challenging. Sometimes they're created by a particular society or a group or a government. And then just being able to access them can be a challenge. So those are some examples of where data could come from when you're designing a study, thinking through how are you going to answer the question that you want. So as you think about a question and you identify the study, I like to kind of run through the finer criteria to see, is this a good study and is this a good study design for my question? So it can be a good study and it can be completely not feasible, right? So if you don't have enough resources, time, and money to conduct the study, it's never going to get done. You might not have the appropriate number of subjects. Like, for example, you want to study a rare disease and you want to do an intervention. But if you're not going to be able to enroll enough of those patients, then it's not going to be feasible. You also need to have the adequate technical expertise with a manageable scope. So that technical expertise might be widening your team so you have others on your team who have the expertise. But is the study feasible? Next thing is the study interesting? So will the answer intrigue you, the investigator, your peers, and the population study, right? So as an editor of a journal, as a clinician, as a researcher, uh, I want it to be interesting. I want your study to matter to you and to others, right? If you're going to take the time to design a study and do all this work, it really needs to interest you and others to say, yeah, I really want to read this. I want to learn from this. And the population that you're studying needs to benefit so that it's a good study. Next up, novel. So is the study novel? Does it provide something new? Does it either confirm, dispute, or extend prior work? Just doing a study in one county that's already been done in the county next door, is it really novel? Are we really learning much from that? Or was it close enough to say, yeah, it applied in that population, it's probably going to apply in this population. There's really no discernible difference to say that this population is uniquely different than the other one. So you really want it to be novel, right? You want to contribute something new. You don't want to just repeat the same stuff if that stuff has already been well accepted and embraced. Okay, the E in finer is ethical. So would it be approved by an institutional research ethics committee? So every study needs to be reviewed. If it is a research study, that means a systematic plan trying to develop generalizable knowledge. You want to present it as a poster or write a paper. Um, that's research, and that research needs to be approved by an ethics board. And that ethics board needs to safeguard the main principles of ethical research. So you could have a really good study, but if it's not ethical, um, then it's not a good study, right? So often we think about the gold standard in study design within medicine as a randomized controlled trial. But if I were to tell you that I was going to randomize this group of participants this evening into smoking and not smoking to see who develops lung cancer, that would be a pretty good study, right? To find out whether smoking is associated with lung cancer. However, it would be pretty unethical of me to enroll all of you into my study and make half of you pick up a smoking habit. So while it might be an ideal way to learn about whether or not an exposure impacts an outcome, it also may not be an ethical way to do it. So always keep that in mind. All right, and then finally, the R in finer is relevant. Is it applicable to scientific knowledge, health policy, and future research projects? Is this going to matter? At the end of the day, when you finish your study, is anyone going to care? And are they going to drive it forward? Are they going to take your study and learn more from it? Or are they going to take your study and change policy because of it? And that impacts more patients, which again goes back to why we do research, because we want to make an impact. Okay, so that's the finer criteria. Let's see if we have a few test your knowledge on finer criteria. So which of the following is the least likely to meet uh, the F of the finer criteria? So, okay, publishing a case series that describes your institution's experience. Let's see. Let's kind of cut off there in mine. Let me refresh this and see if it shows up. Okay, publishing a case series that describes your institutional experience with amputations for diabetic patients, or publishing a randomized controlled trial that evaluates patients who undergo laparoscopic compared to open colectomies at your institution, or publishing a QI project that evaluates the use of hand sanitizers, or publishing a case report. All right, we're out of time. Okay, that's really going to be a determinant on whether or not someone has their device open and can read the entire thing very quickly. All right. Yeah. So I would agree with this. So some of these might not be feasible in any setting, right? If you're at a institution and there's no documentation, it's going to be really difficult to do any type of case series, right? It might not be feasible. Um, it might not be feasible to study whether or not your institution uses hand sanitizer if there's no hand sanitizer in the institution. You may never have a case of gastric varices. You might have never even heard of it. Again, not feasible. But I think uh, the least feasible option is publishing a randomized controlled trial that evaluates patients who undergo laparoscopic compared to open right colectomies at your institution. It's not that it's not feasible, it just takes time uh, to enroll those patients. It requires enough patients undergoing right colectomies. So you have to be at a relatively busy hospital operating. And then you have to be able to justify laparoscopic versus open. And yeah, it's just going to take the time and resources to do it. So I think that was the least feasible of them, but each of them could have their own challenges. All right. Oh man, Benny took the lead with that one. Sorry, Moses. Uh, that was a tough one to have to read all of that stuff. All right, but still close. Which of the following is least likely to meet the R of the finer criteria. All right. Assessing domestic violence risk for women admitted to your hospital. Assessing preoperative nutritional status of patients at your hospital. Assessing the risk of frostbite in Niger. Assessing rates of wound infection after urgent gastrointestinal resections. All right. You can probably see my bias in these questions that I am a surgeon, and yeah, that's what I know and what I talk about. All right, let's see. Okay, yeah, most people agree with me. So the R is relevant. So each of these is fairly relevant to know whether or not there's domestic violence risk admitted to your hospital. That's a relevant topic. It's relevant to know your patient's nutritional status. It's relevant to know the rates of wound infections after doing surgery. But for my colleagues in Niger who never see frostbite, it's not very relevant to assess the risk of frostbite when they never see it. Okay, hanging on to the lead. Okay, which of the following is least likely to meet the E of the finer criteria? All right, which is likely is the least likely? So, a study in Kenya that excludes non-English speaking patients because the investigators only speak English. A study evaluating the safety of a second-line chemotherapy agent for breast cancer, where the medication may increase risk of VTE. A study where patients are compensated for their travel and the medical costs related to their study, or a study where patients will experience discomfort due to the administration of a new medication. All right, let's see. Interesting. Yeah, this is the first question that I disagree with the majority, but doesn't look like anyone had a majority. And this is the beauty of ethics uh, be- and why an ethics review board requires a multidisciplinary team of many different people, including a layperson, someone from law, someone from medicine, and different groups because the collective is better. So the collective on this webinar believe that a study evaluating the safety of a second-line chemotherapy agent for breast cancer, where the medication may increase risk of VTE, yeah, that could be unethical. It could be. But if it's done well and the risks are explained and the benefits potentially justify that increase, that could be ethical. There's more questions there, though, right? Like we need to learn more. Same thing with a study where patients are compensated for their travel and their medical costs related to the study. That could be unethical if that compensation exceeds their travel. Like, for example, you're coming from Narok to my hospital in Bomet, and I cover your travel, including airfare, where I might coerce someone to enroll in my study. All right, so we got to be careful about compensation. Also, a study where patients will experience discomfort due to the administration of a new medication that could be unethical, but also sometimes we experience discomfort every day in surgery, but it benefits the patient. And it's quite ethical, right? To help someone, sometimes there's discomfort involved. But if you don't disclose the discomfort or you um, you don't mitigate or decrease that discomfort, you don't address the discomfort, that could be unethical. But I think a study in Kenya that excludes non-English speaking patients because the investigators only speak English, I think that's unethical. I think that you're excluding an entire group of people just because the investigators choose not to speak that language. So if I do sit on an ethics review committee, and I would take issue with that, and I would suggest that those investigators expand their team and find a way to include others in the study. So each of them have their problems. that is part of ethics. And you need to learn how to mitigate those problems, to really reduce those problems so that you can conduct your study. So kind of here's a list of the things that we might look at from an ethics perspective. And I think you'll have more of this in a future week, but because it's so important to study design, I think we need to touch on it. So there needs to be value in the study you're doing. It needs to be scientifically valid. If we do bad science, that's unethical. We need to have fair subject selection. So that needs to be not somebody who's just vulnerable or who has privilege. Um, and it needs to be fair in who gets included and who gets excluded from your study. It needs to have a favorable risk benefit, like the risk of discomfort or the risk of VTE. It needs to be worth the potential benefit. And that ratio is difficult to define, but it certainly needs to be discussed to say like how you can increase the benefits and decrease the risk. It needs to be independently reviewed by people who are not at all involved in this study. It definitely needs informed consent, where individuals provide their voluntary consent, where the study's been explained to them. All those risks have been discussed, any potential benefits, any disclosures, ensuring confidentiality, discussion of compensation, who to contact, and that they can withdraw from the study. So we need to have respect for our subjects. This is paramount to respect the privacy, allow people to withdraw, and to know that their well-being is monitored. And we as researchers need to avoid and declare any conflict of interest. This is particularly relevant in medicine if a device or pharmaceutical company is involved, it needs to be declared, and we need to make sure that we are not influenced by any financial or other conflicts of interest. Okay, I really just wanted to touch on ethics there. All right, Benny, staying in the lead and kind of running away with it. Awesome. Okay. All right. This might be the last question. I don't know. Feels like there's too much pressure on Benny. Sorry. In a study on a dietary supplement and cancer risk, investigators selected participants who were especially health conscious, leading to an overestimated protective effect. What type of error does this represent? We have selection bias, we have confounding, we have effect modification, and we have random error. Okay. Good. 10 seconds. Awesome. All right. Thanks, everyone. Okay, we're locked. Let's see. Okay, yeah, I agree. Selection bias. So one of the things that we can do as investigators is we can select participants, and that can alter our measures of association, leading to bias. So bias in study design is a lot of what we're trying to limit by selecting the correct study design. So bias is any systematic error in the design, conduct, or analysis of a study that leads to an incorrect estimate of the association between the exposure, often a risk factor, and an outcome, often a disease. So we incorrectly estimate the association between the exposure and the outcome. And what happens with that is it leads us to invalid conclusions. We make wrong conclusions based on that bias. And it can either exaggerate or mask that true relationship between the exposure and the outcome. And the nature of bias is unlike random error, which might happen because you have a small sample size. When you have a larger sample size, bias doesn't just go away because you have a larger sample size. That inherent problem doesn't go away. And it's introduced primarily by us, the investigators, or by our study participants. Okay, so types and effects of bias. We talk about the null hypothesis in a comparison. A bias away from the null hypothesis, it creates a spurious association when none actually exists, right? There's actually no impact of the exposure in the outcome, but because of some bias, we might think that one exists. Or we have bias toward the null hypothesis where we mask a true association, making it appear as if none exists. And examples like the one from the question, selection bias, we've picked a population of particularly health conscious individuals that are taking our supplement, but maybe the other things were there. Maybe they were otherwise doing healthy things like eating healthy and exercising, and that's the reason why they're doing better. But we selected out that group that wasn't a random or representative sample of the population. There's also information or measurement bias, and then there's this idea of confounding. So we'll talk a little bit about that, and I hope you get more of this, especially as we go to evaluating studies. But I think it's important to touch on for study design because bias affects the internal validity, and it has to be addressed at the design stage, right? So if you get to the end of your study, you present it at a conference, and you are then made aware of these really bad bias, it's hard to go back and fix it, right? Statistics aren't going to do it. Uh, so you really need to think about bias at the beginning of your study while you're designing it in order to limit it uh, um, for your conclusions. So confounding is this concept where it's a third variable that is related both to the exposure and the outcome, and it impacts both of them, right? So your confounder, it kind of throws off the relationship between the exposure and the outcome. It alters our understanding of that relationship. It's a confounder or a confounding factor. So I think a good example of this was when we first started looking at tobacco use. It looked as though tobacco use was protective for mortality, right? If you smoke, you are less likely to die. Okay, that was the initial understanding that we had, and that's why, like, um, this is many years ago, like 80 years ago. Uh, so then why did they find that? Why did they find that tobacco use seemed protective for mortality, meaning tobacco users were less likely to die? Well, tobacco users were young, right? And um, those who were not young had already died from tobacco use. So when you look at age within there as a confounding factor, because age was associated with tobacco use, younger people were more likely to use tobacco, and older people were more likely to die. When you control for that confounding factor, or you only look at certain age groups where you restrict to the age group that you're interested in, you'll know that tobacco use, in fact, increases mortality. So you can see how we could have, if we missed that confounding factor, we could really cause some damage between our association between the exposure and the outcome. So there are ways to control for confounding in the design phase. That's one of the beauties of randomization, where we take two similar people and randomly select an intervention and see what happens with their outcome. So that helps to limit confounding factors. We can also restrict, like, for example, in the tobacco use and mortality, we could only look at those who are older than 65. Only look at the elderly and see tobacco use versus mortality. Or we can match. We can take a similar group of people, so similar age, similar sex, similar socioeconomic status, and see match tobacco use versus no tobacco use, and see the outcome of mortality or not. And then there are some things we can do on the analysis phase, but we should do that as at the beginning of the design. Like we should develop that plan at the beginning so that we make sure that we're able to have all the appropriate information for things like stratification and multivariable regression, where we control for confounding factors. Those are important things. All right, so the end. Benny, you did it. You were able to answer all of my questions, and you have the respect of all of your peers. So let's all congratulate Benny with some clapping emojis. Congratulations, you don't get a prize as disclosed at the beginning of this presentation. All right, so if you want to learn more, a lot of this talk comes from an intro to research course that's found for free on Surge Hub through that QR code. It's the Surgical Foundations course, as mentioned. I'm a surgeon and there. So you could go to that QR course if you want to kind of get a refresher, see some of the images that were already on this talk. Also, there's a lot of great content on that website, especially for us surgeons. So there, would encourage you to check it out. All right, so as we talked about the study designs, let's go back to our pyramid of evidence. And one of the things that I want to stress is that every one of these is important. So when I was in medical school, it was the thing was, oh, we got to get these randomized controlled trials. And then it became, oh, we got to get this systematic review and meta-analysis. But really, you can't do those until the rest of it has been built. So you'll note that the very bottom of the pyramid is expert opinion, right? So as a surgeon of increasing age, I'm recognizing the limitations of my opinions. While I think they're important, they're still at the bottom of the pyramid. That background information is the stuff that we need to begin to ask questions, to build on, to challenge, and to learn. So then up next is observational studies, where those case reports, case series, those really are necessary for us to begin to develop the need and the emphasis on cohort studies or case control studies. And then we get into interventional studies to see, is this really making a difference? And finally, we take all of the studies that we have from before, we put them together and do meta-analyses and eventually evidence-based practice guidelines. So all of this stuff builds on itself. I think this is helpful if you're trying to answer a question, to work your way down, to say, is there a meta-analysis to help me answer my question? No. Okay, well, is there a randomized controlled trial? No. Okay. Is there a cohort study? No. Well, has anyone ever seen this before? Oh, good. Yeah, there's a case series of this. So at least I can learn something to help me navigate the care for my patient. But I want us to recognize that these are all very important and shouldn't be minimized because they're all very good. Okay, in conclusion, I'll just again stress that research is collaborative. We can design a study to answer a question. Every study has its flaws. Don't be discouraged by that. Just know going in that, yeah, of course it has limitations. That's part of its design. The goal at the end is to answer your question, but more than likely it will lead to more questions that allow further research, and that ultimately advances knowledge and advances care for our patients, which I know we all share a desire for. So I really am grateful for your time. Thank you for joining with this evening. I think there's a little bit of time for questions. I'm happy to try to take those, but also recognize that we're going to have a bunch of time together, and you'll be able to learn more about each of these things. Hopefully this did provide a overview so that it can lead to more questions. Thanks.